Well, I think we can go ahead and get started, Elizabeth.
Super. Thanks so much, Cindy. Appreciate it. Good afternoon, everyone. Thank you to everyone saying hello in the chat. It's a good sign. We hope to keep you engaged in the chat throughout this process. Thank you for joining us on this webinar, Journey Toward Recovery-Rich Communities. Hopefully you're in the right place. I am Liz Burden. You'll see Elizabeth on the screen. That's so that my mother, if she sees this, who's 90 years old, knows it's me. But everyone calls me Liz, so I hope everyone else will call me Liz as well. I am one of your moderators for today, and I'm honored to be here with you all. I wanted to start, or we're going to start with just a little bit of an overview, and then we'll introduce everyone and do some housekeeping and then jump into it. So today in this webinar, through dialogue, we're going to take some time to pause and reflect on where we've been and where we're going as a recovery movement. In 3 different segments over the next 2 hours, we will have a conversation about the past, present, and future of the contemporary recovery advocacy movement, of which peer recovery support services is an important part. You know, we call it a recovery movement because at its core, people with lived experience of addiction and recovery and their allies have come together with a shared purpose to promote recovery. William White, in his 2016 blog post, New Recovery Advocacy Movement Basics, noted that this social movement is aimed at changing public and professional attitudes towards addiction recovery, spreading recovery-focused policies and programs, and supporting efforts to break intergenerational cycles of addiction. Movements such as this are incredibly important. To build recovery-rich communities, we must change hearts and minds, policies and laws, culture and environments, and that is what movements do. Now, we call it contemporary because the work that we are all doing builds on the history of earlier recovery-related efforts, such as the past work of the National Council on Alcoholism and Drug Dependence, the Society of Americans for Recovery, and other organizations across the 20th century, including late 20th century, the Recovery Community Services Program, and the Addiction Technology Transfer Centers, much work that happened, along with the efforts of countless informal groups and individuals. Our work also builds on models of recovery that have been passed down in diverse cultural communities dating back to the 1700s at least. So we're part of a long and proud heritage. While our current challenges may be distinct, our current responses are both innovative and they're rooted in a long history of one person helping another. You know, I'm honored to be an ally in and for this recovery movement, and I have been since the mid-1990s. I'm not a person in recovery. I don't even play one on TV. Yet I am steadfast in my support because I have seen and felt the power of recovery. I've had the privilege of working with amazing individuals who shared their stories of change, who lead with their hope, who inspire with their vision, and who work tirelessly so others can get what they got. And many of those folks are on this panel or on this webinar today. Through my connection with the recovery community and relationships with people in recovery, I have learned a great many things that I carry with me to other communities. I believe that the principles of recovery and that ground this work are relevant to other social change efforts and communities across the country. And that brings me back to our theme for the webinar, Journey Towards Recovery-Rich Communities. I believe, and I hope and think that is likely that you do too, that every person deserves to live in a place where they have access to everything they need to live healthy, self-directed lives and have ample opportunities to reach their full potential. Where it is the expectation that everyone will have health, good health, a safe and stable place to live, meaningful daily activities, and relationships and social networks that provide support, friendship, hope, and love. That's a recovery-rich community. We aren't there yet, but we're well on the journey. Now, why and how is any of this relevant to the Peer Recovery Center of Excellence? As the science of recovery continues to evolve, it confirms what people with lived experience know, that recovery from addiction happens in community. On our journey toward recovery-rich communities, we must connect individual recovery, that is personal transformation, to recovery-oriented systems of care, that is institutional transformation, to communities that have vibrant recovery ecosystems, that is community transformation. All of that is important. A vibrant recovery ecosystem includes mutual aid organizations, local and statewide recovery community organizations, recovery housing, harm reduction services, medical and specialty treatment, social services, and so many other services that I'm not going to have time to name here. A vibrant recovery ecosystem is more than the sum of those parts, though. Peer work, formal and informal, volunteer and paid, is central to a vibrant recovery ecosystem and is supported by it. From the stories that you share of recovery privately and publicly, to peer recovery support services that are offered within many types of organizations, to advocacy work, the direct service and advocacy of persons in recovery, that is peers within local and statewide recovery community organizations, makes individual and other settings, makes individual, system, and community transformation possible. We know that RCOs, recovery community organizations, ensure that supports and services have an authentic recovery orientation and are grounded in community wisdom and experience. Neil Campbell, the executive director of the Georgia Council for Substance Abuse, which is a statewide RCO, reminded me of the power of coming together locally, across states, across regions, and nationally. She noted that RCOs, especially statewide ones, serve as conveners of all things related to recovery, promote recovery-focused policy change, mobilize people in recovery and our allies, help to train and prepare the peer recovery workforce, and are catalysts for changing social norms. And that's why the Peer Recovery Center works on building the capacity of RCOs. We also know that recovery community centers, recovery residences, recovery schools, recovery-friendly employers, all of these things are places in which persons in recovery, peers, are operating on a daily basis to bring the hope of recovery to their communities. So our panelists today will share where we've been and why that matters, where we are, and how all of those parts of the recovery ecosystem are making a difference and where we're going. The first segment, Where We Have Been, will be moderated by Patty McCarthy, who is the CEO of Faces and Voices of Recovery. I'm not going to read her whole bio. I'll tell you that I've known Patty for a long time, and she's just a wonderful person to work with. If you're wanting to see more about the bios of her and others on our panel, Cindy's going to drop a link to the full list of panelists and bios on the website. But Patty is going to be joined by David Mineta, Lynetta Albright, and Andre Johnson as they talk about where we have been. The second segment, Where We Are Now, will be moderated by Kristen Harper, who's the Director of Recovery Innovation at Faces and Voices of Recovery. She'll be joined by Efren Baez, who's with Stairway to Recovery, Jennifer King, Council of Southeast Pennsylvania, Ahmed Hosni, who is with Association of Recovery and Higher Education. I hope I'm right. I think I'm right about that. And Corey Villasant, who is a researcher with Recovery Research Institute, or a fellow with Recovery Research Institute. And the final segment, Where We Are Going, will be moderated by Chris Kelly, who is the project manager for the Peer Recovery Center of Excellence. She's going to be joined by Keegan Whips from Faces and Voices of Recovery, Christina Padilla, and Mark Jonigan. Before we get started, we have one other thing, and that's some of the housekeeping things that Cindy talked about. So Cindy, what do we need to know as participants?
Hi, everyone. Let me share my screen, and I'm going to do this in hopefully about 45 seconds so we could get started. Okay. Well, my name is Cindy Christie, and I am a woman in long-term recovery, and I'm just so grateful to all of you for being here today, and happy Recovery Month. So for today's event, all attendees will remain muted. We will use the chat feature to communicate. All of our panelists will be engaging in the conversation via chat when they're not speaking. So questions and comments are welcome. We hope to have a rich conversation. So please make sure that you select everyone on the drop-down feature after the word "to" in the chat pod. We also have a Zoom technician available, Cody, to help you with any technical issues. So please preface your chat message, with tech issue. We do not have slides for today's webinar other than these. Our moderators and panelists will be on camera throughout when they're speaking. We are recording this webinar. The recorded sessions will be posted on our various websites from all 4 of our national collaborators. We are offering certificates of attendance for this event. We'll send you the information and a link to download your certificate of attendance for today's event in approximately 1 week, and it'll come from me, Cindy Christie. Okay, today's webinar, I gotta move my screen around so I can see this. Today's webinar is being live translated into Spanish. So say hello to Sebastian, our translator all the way from Santiago, Chile. To hear the Spanish translation, please go to the bottom toolbar and click on the language icon, and you'll be able to choose Spanish or English. We're sorry, we did hope to have this webinar translated live into American Sign Language, but we're sorry we couldn't quite pull that off due to some technical issues. We have engaged the live transcript feature, which you can turn on or off simply by clicking the CC icon on the toolbar. We will have an evaluation link towards the end, so hoping that you all will take a moment to do that. I just shared the bios in the chat and we'll continue to do that. But thank you again to all of our panelists and our meta moderator, Liz. I'll stop sharing now.
Thanks, Cindy, really appreciate it. And with that, let's start with the first panel. So Patty McCarthy, please take it away.
Thank you, Liz, and thank you, Cindy. It's a pleasure to be here today, and it's our privilege to be co-sponsoring this event from Faces and Voices of Recovery and our co-sponsors here today. And it's especially exciting to be celebrating National Recovery Month, now in its 32nd year. And this is a great way to observe National Recovery Month. National Recovery Month is now an international observance, and I'm so thrilled to see. I was following the chat. There are folks here from Switzerland and Canada and all parts of the United States. So very excited about that. I am thrilled to introduce my esteemed colleagues on this panel, which will talk about where we have been over the past 20 plus years in the national recovery movement. So first, I'd like to introduce and welcome David Mineta. David is the president and CEO of Momentum Health based in San Jose, California. And prior to that, he was a presidential appointee in the position of Deputy Director of Demand Reduction for the Office of National Drug Control Policy at the White House. And I'm especially pleased to have him here also as the chair of the board of Faces and Voices of Recovery. So thank you, David. I'll also introduce Lynetta Albright. Lynetta is the president and CVO of Forward Movement Incorporated, executive director of John Maxwell team, and the principal investigator for Great Lakes ATTC, now retired from Great Lakes ATTC. But she is an author, radio personality, change agent, and facilitator, and one of the most dynamic and transformative speakers, facilitators, and coaches working around the globe to add value to and changing the lives of thousands, I'm sure thousands and thousands of people. So next, I'd like to, I will welcome Andre Johnson. Andre is a native Detroiter, and he's currently the president and CEO of the Detroit Recovery Project. It's a multi-service agency that provides a wide spectrum of support services in the city's recovery community and has an amazing model of an RCO there in Detroit, Michigan. So I am, it's an honor to be here with all of you, and as well as the other panelists throughout today's program. So I'm going to get started by asking a question of each of my panelists actually today. Just to give us a perspective, in your opinion, what were the major catalysts that sparked the recovery movement? And I'm going to start with Andre Johnson. Andre.
Well, first of all, good evening, everyone, and thank you, Patty, and the esteemed panel that I get to have the opportunity to join today. But when we talk about the recovery movement, where we've been, I think in the very beginning, SAMHSA was very instrumental in launching the recovery grants, which were focusing primarily on advocacy. And I think we had this huge momentum where it may have been somewhat overwhelming to the federal government. They changed the title of the grant to Recovery Support Services because I think it began to be a fine line between advocacy and lobbying. But I think that was really a major component to kind of the whole movement of the importance of rallying and bringing people in recovery together and using people in recovery to help other folks who are trying to obtain recovery, seek long-term recovery, also outreach to people in early stages of recovery. And as you know, Patty, the whole the recovery messaging training started shortly after that movement, where we started a unified approach to introducing ourselves as individuals in long-term recovery. And I think everybody here knows that spiel. But I think we've come a long ways in these last 20 years.
We sure have. Thank you, Andre. And that reminded me of, you mentioned when the SAMHSA first funded the grants for the recovery support services. It was in 1998, and the Recovery Community Services Program. It was started as actually Recovery Community Support Program, the RCSP grants. And midway through that first cycle, they shifted from support, where we could do advocacy, to having to do services. So I was also part of one of the original cohorts of grantees in New England. And so, but I want to give credit real quick to Dr. Wesley Clark and Kathy Nugent and Marcia Baker from SAMHSA back then, that really were visionaries for where we are today in the development of recovery support services. So I'll ask Lynetta as well. What do you think sparked the recovery advocacy movement?
Thanks, Patty. Hello, everybody. I'm really excited to be here. When the ATTCs call me, particularly Lori and Cindy, I have to answer. And it's just such an honor to be here. 20 years ago, I said I wasn't going to date myself today, but I was in the room, Patty, when we were starting all of this. And I think we had the honor of helping to not only craft messages, but to write them down and get publications out and articles out. I remember the first one we did with Bill White, where he asked the addiction treatment field if we really believed addiction was a disease, what would we do differently? And that question continues to carry forth as we're working with providers. When I think about catalysts, and David Mineta may talk about this, the New Freedom Commission that sort of talked about we needed to have a fundamental redesign of how we were doing behavioral health. And that was a catalyst for us. But the other thing I think, you know, when I talk about history, or when I think about history, I think about the people. So when you ask the question about catalysts, I can't help but, you know, I'll name drop, and I'm sure I'll miss people, but I don't care, because some of these people, if not for them, we wouldn't be here. The late Tom Kirk, who he and Dr. Arthur Evans in Connecticut, I call them the architects of this, and Larry Davidson, folk out of Yale, and then the incomparable Dr. Ijama Achara. We wouldn't be in the room without these people, you know, so I have to raise up names, Patty, when I think about the history. Tom Hill, Phil Valentine, when we first started in Detroit, my mentor, Dr. Calvin Trent. And I think just so many people I could name, they were the catalyst, Peter Goldman. If not for the courage to just say, we're going to do this. We're going to do this. It's going to be hard. And we're going to have a paradigm shift. And I would tell Bill, paradigm is a beautiful word, Bill, but we got to figure out how to do this. How do we make a paradigm shift? So for me, I see, Lori, you put Mike Flaherty. These folk were the catalysts and the pioneers, Patty. That's what first comes to my mind when I think about your question. Hope that's okay.
Thank you. Oh, absolutely. We are standing on the shoulders of giants.
Yes, we are.
Things that came before us.
Yes, we are.
Yes. And for those that might not be familiar, most everyone is probably familiar with William White. But if you want to check out his website where all of his publications are, it's williamwhitepapers.com. So I encourage you to do that. Now, I'll ask David, from your perspective, what was the impetus, the kind of the catalyst for the recovery movement? And from your perspective, what have you seen from being at ONDCP and now in your local community?
Thank you, Patty. And just want to make sure, can you hear me okay? We had earlier technical difficulties. So, well, thank you. Thank you for this invite and to be on this panel with Lynetta. And it's great to see you, Lynetta. Great to see you, Andre. It's been a little bit. You all look great. Haven't changed. But I would sort of want to pick up from where Lynetta just left off. And again, the names and all are significant, right? And you know, they just paint that last 20 years. But one thing I would like to focus on is the connection between the local grassroots efforts and what happened on the state and national levels. Because it was what was happening on the local levels that drove state and national and the federal government to recognize recovery and the true, I think, power of recovery. And that connected public-private partnership is so very important. You know, it can further sort of that and has furthered that movement on both sides. So again, I have to mention Bill White. It just feels like you know, we all must recognize his body of work, and particularly around the history of the recovery movement. And I'm very proud to have been a very, very small part of that movement from the government side and developing recovery through White House support. I mean, I think that was so important. And I think under President Obama and the first director, Gil Kurlikowski, we intentionally raised recovery to the same level as prevention and treatment on the federal level, right? So it may have been mentioned before, but all of a sudden we have a recovery branch, and Lynetta mentioned Peter, who's on right now. I just want to mention that Peter was the first recovery branch chief at ONDCP. And 11 years later, Peter's still at ONDCP. How lucky are we? Director Botticelli was the first person in recovery to be ONDCP director. And I don't know if you all remember, but we had his swearing in ceremony at N Street Village, and White House Comms actually did a live feed of that event. And since this is our recovery community, celebrating National Recovery Month, I hope that some folks remember that event. And because it was significant, again, a person in long-term recovery, first director at ONDCP, having his swearing in at a women's recovery treatment center in DC. Again, pointing out that how important recovery was. I had a speech in the Midwest, and at a conference, a woman came up to me and she introduced herself. She said she was from Alaska. She was trying to cite a women's treatment facility for women coming out of custody. who wanted recovery support. And as she was talking, she said, I saw that swearing in. And I'm having a hard time citing this recovery program for women in Alaska. And then she started, I could see a tear forming in her eye. And she was talking, and she said how important it was for her to watch that swearing in ceremony. She said she was going to actually keep on the mission and get this program started. Supporting an individual's recovery does so much for one person and their family. I mean, it's amazing, right? But it can also start and to sustain a recovery movement that we are all a part of, that we are privileged to be a part of. So I just want to say that partnership between the public and the private is so important, and to have leadership in White House, SAMHSA, across the government. And I just want to say, in addition to my colleagues, my former colleagues at ONDCP, Peter, I think carries on. But I want to call out Tom Coderre. So Tom's on right now. Tom, how much has Tom done for recovery for all of us? So again, it's about people. Love it. And it's also about systems and advancing these systems. Yeah. So thank you all. I mean, it's just such an honor to be here and a privilege to be in this community.
Patty, if I could just add one more piece before we leave this question, is around research. And we didn't have a lot of research about recovery. However, we had some great researchers that were part of this. Dr. Laudette, I just remember one of our early events with Dr. Laudette, Mike Dennis and Chrissy out of Chestnut, and Mike Flaherty, and they started asking the questions. And the most impactful question for me was when Dr. Tom McClellan said to me once, Lynetta, we've been measuring treatment. What we should have been measuring is long-term recovery. And so we've been measuring the 21 days in treatment or residential treatment, but we want to understand what it takes for people to achieve and maintain recovery. So I think we can't leave the research out, even though we didn't have a lot, we had some. So that was a big catalyst as well.
Absolutely. Thank you so much for that, Lynetta. The research has absolutely helped launch us into a new dimension, really, for recovery support services. And those that you mentioned, Dr. Alexander Laudette, who helped us do the Life in Recovery survey, which gave us so much information about what recovery looks like. And also we have Dr. Corey Villasant from Recovery Research Institute. That's one of our panelists today, and Dr. John Kelly and his work. So lots has been done. I'm going to move on to another question to ask Andre. What have you seen in terms of the impact of the voice of the recovery community on the state and national level to making change by lifting up our voices, being loud and proud, and recovering out loud?
Yeah, I think that we've certainly had a unified voice, both nationally and statewide. And I think, obviously Faces and Voices of Recovery, being our national advocacy organization, has been very instrumental in helping local and state communities to have a unified voice, and language has been a major component. I think that, but it's an ongoing process. It's an ongoing process. We know we can't rest on our laurels. Here in the state of Michigan, I've seen us, we've worked through 3 governors, 5 mayors, a number of a whole new city council has shifted, and with politicians, new policies, new flavor, new energy, and we all know how that works out. But I'm very, very grateful that we've been able to have a strong presence, which David mentioned earlier, in terms of ONDCP and SAMHSA and Tom Hill and Tom Coderre and our partners. And so I think the most important thing when we talk about growth of the recovery advocacy movement and the voice on a national and state platform, in the last 10 years, I've had an opportunity to travel to several states and sit down with the state leaders and listen to them talk about recovery and how it's important and why it's important. So I'm just excited. Y'all know I'll be talking all day.
I know you have so much to share and so much wisdom, each of you. I know you do. I want to actually ask each of you to give, from your perspective, some lessons learned or words of wisdom for the next generation of recovery advocates. So with the time we have remaining on this part of the panel, what would you say to the recovery advocates out there, the recovery support providers that would help them, and your key takeaways from the past 20 plus years? And who wants to go first?
I'll go first, Patty, because I've got this just right on my mind, and it's all about leadership. And for peers have just taught me so much over the years. We can't do this work without people in recovery, and to see them really believing in their potential as leaders is important. And for not only RCOs and RCCs, but also for our providers to really create a culture of leadership when we talk about our peers, and for our states. In Florida, they put a person in long-term recovery. Wes Evans is at the top of the work that we're doing there in Florida. So I can't say enough about leadership. Sharon Heseltine and I have been training peers in Kentucky and across the country now, and leadership is a big piece of it. And the last thing I'll say for advocates and peers is to don't underestimate or take for granted their self-care. So self-care is a big piece of this. And so my advice is leadership, self-care. I told Andre years ago, I think people in recovery could change the world, but I'll leave it at that.
Yes, I love it. We are changing the world, right?
Yeah.
If there's anything that I think what makes me most proud of being part of this movement is that we are able to use our voice to eliminate the stigma of addiction, that we're able to help people, and we have a ways to go, but it is about putting a face and a voice on recovery and sharing out loud. I just want to say, leadership starts at every level, and that what we've seen this year with the highest levels of government, starting back with Michael Botticelli as the director of the White House Office of National Drug Control Policy, but also we have the Secretary of Labor, Margie Walsh, and openly in recovery, as well as Deb Haaland, of Secretary of Interior. And this is just incredible. We've seen a lot of growth over the years. So I'll ask David, what are your words of wisdom, lessons, key takeaways for the new recovery movement, the new advocates?
Yeah, I mean, the new advocates, it's sort of interesting to me, Patty, that, and you and I have a chance to talk about this and to work on these sort of ideas and issues from Faces and Voices. So I just want to say thank you to you for that opportunity, to you and the staff. I feel so privileged actually to be associated with Faces and Voices, and particularly right now at the 20th, sort of anniversary of the movement. So I actually am thinking about a meeting that I had when I first started at ONDCP with a bunch of young folks in recovery, who turned out later on to actually be folks that actually moved the whole field in the movement around young people in recovery, and anonymous people, Greg and Danielle. I mean, just folks that were just like so unbelievable. And again, in that leadership of that moment, that young people are the next generation, are going to change and take our seats, and they're the next leaders to actually move and push this to the next level. And that is so exciting to see all over the country. People of all demographics, races, ethnicities, orientation. This is the biggest boat in the country, filled with everybody. And the power of it is so amazing. And so that next generation, man, I can't wait to retire and watch folks, the 20-somethings and all, move in and take this to that next level. Let's go. Let's go.
Yes, let's go. Let's do this thing, right? All right. And you remind me, David, that the recovery movement is a whole national infrastructure of services, but that's everything from recovery high schools, collegiate recovery programs, recovery residences, alternative peer groups, reentry programs. We are advocating to build that infrastructure, and we need the young people and young voices to come along and help us build that. It's a great vision to have, and we've seen a lot of change. So I will ask Andre your view on lessons learned.
So I certainly piggyback off Lynetta and both David in terms of the importance of developing ongoing leadership. I think that's important, and that research is important, and working towards establishing best practices, the continuation of establishing best practices, but also Patty, I love what you said in terms of peers are working in all segments now. Peers are working in prevention, they're working in treatment, they're working in recovery, they're working in federally qualified primary health care centers, prison systems, mental health facilities. We've expanded peers in this area. And most important, I think, if we're going to continue to build partnerships with our government, it's important that peers understand the political landscape that involves their local communities, their state legislature, as well as county, etc. I think because at the end of the day, we've been heavily supported by our government. And so we got to continue that momentum. And then lastly, one lesson I would say learn is not to depend on one financial resource for your organization. Create a diverse revenue stream for your organization. And perhaps that can be being creative as best as you can. And I think that's the beauty of recovery, is that we've been able to be very creative and do this work. And no limitations. Don't set no limitations. Let me tell you a quick story. Lynetta was in Detroit one day and she said, Andre, you want to go to Africa? And I said, yeah. And then the next week she said, I need your passport. We're going to Africa. And we was on a 5-year project going to Africa. And I couldn't have imagined that the work that we've been doing would lead us to another geographic country like East Africa. And we have memories and some of the best times of our lives, I think, in Zanzibar and Dar es Salaam. And so I think recovery is just opening up all over the world, and we don't need to limit ourselves. Let's take it. Let's take the bull by the horn.
That's right. Thank you, Andre. And I'm just going to close us out by reminding everyone of the words of wisdom from Tom Coderre, that we are a constituency of consequence, and without getting involved with our political system being a social change movement and advocating, we can't make change. So we need to continue to build on that. And that has to do with civic engagement, voter education, educating the candidates, talking about what's happening out there, and really making recovery possible for even more Americans. We know that there are over 25 million Americans in recovery from alcohol and drug addiction. We know that worldwide in those international movements, you've been to Africa and all over the world. We have Faces and Voices of Recovery, Brazil and Canada and South Africa and United Kingdom and Canada. This movement is worldwide. So let's, I really appreciate the history that you've all brought to this and where we've been. And thank you so much for sharing your words of wisdom. I'll turn it back over to Liz.
Thanks so much, Patty, Lynetta, David, Andre. Really do appreciate all of that as well. From where we've been to where we are now. Next up, Kristen Harper is going to moderate the panel that allows us to talk more about where we are now. So Kristen, take it away.
Thank you, Liz. And thank you so much to the panelists and to Patty that just went. Y'all walked me down memory lane. I'm a woman in long-term recovery. And for me, that means that I haven't used drugs or alcohol since March of 2001. So Faces and Voices and I are both turning 20 this year, or I turned 20 in March, and now Faces and Voices is turning 20 next month. So it's been a really cool process to grow up within the recovery movement. It's been tough growing up in public, though, I will tell you that. So let's jump into it. So we have some really great panelists here. I can't wait to start chatting with them. And so I'm not going to kill any more time. We have Efrain Baez, who is program director at Stairway to Recovery. And he is in Puerto Rico, from Puerto Rico, and is doing some really cool work as a peer and as a program director. He's worked in the field for over 20 years, and his experience includes residential supports at House Casa Esperanza and Latin American Health Institute and Gandara Center. He's done a ton of stuff. He's also participated in one of the first CAPRIS accreditation processes for our RCO accreditation process. So welcome. And we are also going to chat with Ahmed Hasni. Ahmed and I have actually been to Afro together on the West Coast, Andre, not the East Coast, doing some recovery work together. Ahmed is the Assistant Director of Student Life at the Wellness Center at The Ohio State University, and is also the Director of Recovery for the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. He's also on the board for the Association of Recovery in Higher Education, and is also someone with lived experience. And so we're really grateful to have his perspective today. And then we have Jen King, who's the Executive Director of Council of Southeast Pennsylvania, or PROACT. And Jen served most recently, previously as the Director of Advancement for Penn Foundation. And they, of course, have the largest recovery walk, I think, ever recorded in history so far. So we can't wait to chat with Jen about what they're doing there in Pennsylvania. And then, of course, we have Corey Villasant, Dr. Villasant, who has done some really amazing work in helping us raise or amplify recovery research to really help us further our mission. And best practices and evidence-based practices hopefully will start emerging in the next couple of years from her work. So let's jump into it. I'm going to go to Jen first. We just heard a little bit about the history of the recovery community. So let's shift to what's happening today. You are doing a ton of stuff. You're hooked into so many different peer services in a variety of different settings. Can you tell us the role that peers are playing in these settings?
Absolutely, happy to do so. Although first I need to, come with my gratitude practice, and Lynetta hit some of exactly what I wanted to start with. Those of us doing the work right now know we owe a deep debt of gratitude to the heroes that have come before. And for me personally, that's my predecessor in this seat, Bev Haverly. Someone mentioned Dr. Evans. So his time at DBH IDS with Dr. Achara, and currently Roland Lamb, the Deputy Director of DBH IDS in Philadelphia, who retires on September 30th. So I personally want to thank those individuals for helping me. And Roland, especially, his example of servant leadership is inspirational, and I kind of am still in denial that he's going to retire. But yes, we just celebrated our recovery walk. We were, in the interest of safety, we had moved to virtual. We had really spent most of the summer hoping that we'd all be in person. But lots of people walked in their community. Lots of legislators sent videos, and some came and were part of our live program. And I also just want to note that the power of stories becomes more evident to me in our virtual work than even in traditional pre-COVID times, because what I've realized is the legislators who chose to be part of the walk and shared their story reflected on their personal connection to recovery in ways they don't always do from the stage and the microphone when they're talking to 30,000 people. This work touches everyone, and it's really just so powerful to hear someone talk about their own recovery, or they're watching their child recover. I think about the theme for this month came through in so many ways. Really, it's every individual, every family, every community. That's part of what, and then that theme also works with what I'm going to describe, because really that's true for the work that peers are doing in our organization. But I'm also going to say that I'm broadening this and thinking about the other nonprofit providers, the other partners in the Southeast Pennsylvania region. Lots of us are doing this work, and we really are collaborating. But it's interesting that one of the problems I'm facing as an executive director and my HR team is a real problem, and it's a challenge for us in an HR perspective. But man, it's a credit to the work of the last 20 years, because one of the challenges we're finding right now is hiring and retaining CRS staff. That's our word for peers, certified recovery specialists. And the market is really competitive. We talked about Tom Coderre's constituency of consequence. This is a workforce of consequence right now. And really, that is a wonder. I'll face that problem any day of the week, so that we're turning to our board and saying, how can we make sure that we're paying competitive salaries? How can we make sure that we're doing the things that will encourage retention? What a great problem to have. And I'm sure that if we go back in the time machine and jump off 15 years ago, if I complained about that problem, then they'd say, that's exactly what we want. That's what we want. So I love that example, because I really do think it is such an indicator of the work of the heroes who came before. So to that end, we have a lot of different employers of and I'll say peers, but in our area, they're called certified recovery specialists. We have a lot of employers of those. So I'm, of course, a nonprofit provider, and I hire them for our programs, but they're also being hired by the hospitals themselves to do warm handoff. They're being hired by, as someone mentioned before me, that I think Andre talked about, they're being placed in clinics. They're being placed in programs where they're really working as peers. So that's been really exciting to see that grow. I think about the way that an individual can be transformed by the work of a recovery specialist. They can transform their lives. But what we've also learned is that the work of peers embedded in workplaces transforms the workplace. I've had a director of nursing talk to me about how, for years they tried to work with the staff and reduce stigma and help the staff on the emergency department frontline understand, the concept of recovery and the concept of meeting people where they are, and, just broadening that understanding for their medical staff. But that months after they were working side by side with a peer, that work just jumped leaps ahead, because the work of knowing, oh, this is Michelle. Michelle is my coworker and my colleague. But when she sits and talks to that person who right now is really sick, is really disruptive, is really in pain, and she speaks with him and with such compassion and such understanding and such humanity, and then turns to me later and says, I was there, he was. I've been there. That just modeling and embrace of an approach goes so much further than a training ever could. So, that work is kind of the ripple effect and the exponential benefits of this investment in these programs. So in our case, peers might be working in our recovery community centers. And I think about kind of the life cycle of an individual at a center. Someone might start at the center on the first day out of an inpatient program, where someone really pretty much said, this is what you need to do today, is go to the recovery center. And they might not have wanted to be there, but they'll go. And then a couple of days later, they might be like, okay, I get this place. They seem to like me. They seem to have a recovery orientation. I'll stay and I'll keep coming back, and I'll go to groups. And as my recovery gets stronger and stronger, I'm going to find a place to belong. And then a little further down, they might be like trained as a volunteer because they want to give back. Part of their recovery work is giving back. So they might become trained as a volunteer and then start to volunteer in the work of the center. And then a little more of their work says, I think I might want to do this work. And we have support from the city, we have support from the state, we have the support from the national level to provide training for CRS. And so they get that training, they get that education, they build that professional kind of work toolkit. And then they might work for us, might work in one of these other places. And then their, professional development might mean that they're going to get snapped away from us and taken to a new professional role. And then what they might want to do is give back. And in our centers, the vision team is our volunteer leadership. They might play that role. I had the experience this past year of watching someone's commencement address, and he was getting his MSW, and he was the commencement speaker for a well-known university here in the Philadelphia area. And he told exactly that story about the beginnings of his recovery and coming into one of our centers, and then our paycheck when he was first working for us being the first paycheck he had because his life of use meant he wasn't working before that. So, and then, a couple of years later, I'm watching him give the commencement address for a major university. So that's possible. The peers make that happen. They make that possible. Then in our communities also, police and emergency medical services have really embraced the model, and they are embedding CRS in their programs. We have both in the city and in some of our counties, the police system is embedding peers, and there are mobile responses where peers are going out to the community. They're meeting people where they are, they're educating them and informing them with the multiple pathways, trauma informed, and really just spreading that word that recovery is possible.
That's incredible.
Yeah.
Thank you so much for all those examples, Jen. I was just doing some calculations before prepping for this. And I think that there's an estimated 30,000 or so operating recovery support specialist coaches across the country. And if they're only seeing 4 people a day, even that averaged out to be over 31 million engagements a year.
Oh, wow.
It may not be with 31 million different people, but still 31 million million engagements is just an incredible number. And so peers are certainly, I think, a huge, huge part of our infrastructure and the services we're providing. So thank you for that.
Absolutely.
So let's go to Ephraim now. It's wonderful to chat with you. I've heard so much about your work over the years, and I wanted to find out more about Stairway to Recovery and how the local community is responding to the recovery support services there.
Thank you, Kirsten. And first, I want to say Happy Recovery Month to everybody, and also Happy Hispanic Heritage Month, because they start in September 15 in October, and end October 15, the Heritage Month. So, but when you guys invite me to speak a little about the work that we do here at Stairway, I am kind of not so much of a good speaker when it comes to talk a lot. And when I start seeing the names, and my coworkers say, "Frank, you have been doing this for so long." I opened the center back in 2008, and I have been involved so many events and so many projects, and I see how much the center has grown and how many people has come to the center and benefit from the peer-to-peer services. I say, I gotta say something. I gotta sit in here and express and tell you guys how much I appreciate this job and how much the center, because I say the center, not me, because I am the director, and I always try to not forget the direct contact with the members who comes to the center, despite all this year with the COVID and all that. So we open back again in September, but throughout the years, Stairway to Recovery has been involved in so many projects. I remember back in 2008 when we opened the center. This is a shifted completely what it is right now. I remember I used to go to the DCF meeting. I used to go to the court meeting and bring some peers, and it was very tricky. But the people know, the people who was working in the community know the Stairway to Recovery with the peers has something, bringing something special that they haven't seen. And this is the people in recovery try to get recovery and help the community. So throughout the years, workforce development, we brought workforce development for the peers in here. They come, we have volunteer opportunities for them. We build leaders and the thing is that the mayor is also involved. We just celebrated the 13th anniversary, and we, for some reason, we did forget to invite the mayor. The mayor was here supporting us. So we, every activity that is around the South Shore, like the overdose billion, we Stairway to Recovery is involved. You're talking about, when it's about recovery, Stairway to Recovery has to be there. And also, I just want to share that we just moved to a new location that is right on the main street next to, it's very, very, very special for them. And this is a place when they come in, they feel like there's a treating with dignity and respect. So, and this is what I love the job. Like so many people say, I'm hooked with the job. And 13 years later, I still like coming to work like the first day, because it give you a sense of that, you know, that you doing good for the community. You see somebody coming with a baggage, and 6 months later, on their own pace, they can, using the participatory process, all the peers telling, come in, I was there, and 6 months later, you see them answer the phone in the front desk, holding a position as a peer leader, making something for themselves, and this is what we embrace. I said, and we value the power they coming with the urge to change their life, because nobody want to be sitting in that position. So Stairway to Recovery has been very instrumental around Brockton and South Shore, because it's the work that we have done over the years.
Absolutely. And I can just tell your passion for the work. You just kind of glow, your energy's coming through a Zoom meeting, which is really hard nowadays. So we definitely can tell that you love it. And 13 years is a long time. 13 years is a long time. Congratulations on the new space.
Thank you. Thank you.
So let's go over to Ahmed. Ahmed and I go way back. We flourished in West Texas together. I got started in collegiate recovery and got to work at Texas Tech University, which was one of the first collegiate recovery programs in the nation. Ahmed, we both know the history of collegiate recovery. We've touched on it a little bit here, but not a whole lot. Can you tell us a little bit, just 3 to 5 minutes of sort of the evolution of collegiate recovery? And really, let's focus on where we are today, especially when we talk about equity, diversity, and inclusion within the recovery space in education.
Yeah, absolutely. And so it's a great question that you could do justice in an hour with. And so I'll do the best job I can in 3 to 5 minutes for sure. But I also want to say that I wish I'd have gone first, because everyone before me has got me gassed up, man. I'm just pumped to be on a panel with so many amazing people who are doing such great work. And so, so I have the honor of being a co-chair for our Association of Recovery in Higher Education, but I also work at Ohio State's collegiate recovery community. And I was a student at Texas Tech. And so collegiate recovery has shaped my life, and I've watched it evolve over the years. And I don't think any period of time saw more evolution than these last 3 to 5 years. And today, right? It's a field which is living and growing and evolving every day. And I think a lot of that is because we've had a reckoning on college campuses, especially in recovery spaces. And that reckoning kind of falls in line with the reckoning we felt in society on social justice, on racial justice, and on the movements to provide equity across the board. And so as a collegiate recovery staff person and as a field, we have a responsibility to ensure that every student who walks through our door has the opportunity and the resources available to them to not only enter into and enjoy recovery, but to thrive in it. And it's not an easy thing to do, because we have to remember that we're talking about systemic oppression that's over 400 years old, and it's by design and it's intentional. And so for us, it's important to, like everybody else who's been pointing out all the people that helped get us here, for the collegiate recovery community, it's important to point out all the students of color, all the LGBTQI students, all of the people who spoke out and said, there's a problem with this space. There's a problem with this field. I don't see enough people that look like me here. I don't see enough people with the same lived experiences as me here. And what they did is they called us to task. And I'm so grateful for people who have that courage. I don't know if we honor them enough every day, the courage to to walk into a space and say, y'all aren't doing good enough. And so we've tried to take that to heart. I think that what we've seen is diversity, equity, and inclusion in collegiate recovery is no longer can just be a webinar we do once a year, right? It needs to be the lens through which we see our work and how we approach our work. It needs to be it needs to be the policy and the philosophy that if Black students, if Latinx students, if Asian American students, if Asian born students, if our LGBTQI students, if any student isn't safe and supported in our space, then no student is safe and supported in our space. Because if we make sure that it works for everybody, then it works for everybody. And that's what we try to do. I know that that's what we're trying to do at Ohio State. And I know that that's what the calls that we continue to have on a national level, that's what the investment that we continue to make in for preparing the staff who are delivering these services on colleges, college campuses looks like. And I'll say that we've only begun to scratch the surface, because this is a dynamic, complex problem that it took a long time to get to the place that we're in now. But it's going to take us as a field, it's going to take us as a movement to turn these conversations around, because these aren't only issues that are happening on college campuses. This is a recovery issue. And I know that for me, when I think about collegiate recovery, I think the one message that I want to get out is that, I love collegiate recovery because it changed my life. I am a Middle Eastern man who has a felony record, who was a result of my drug use. I've been in recovery now for 15 years. And what it's given me the opportunity to do is to get 2 degrees and to support my family and to have a better life than I ever imagined before. And the problem is that my experience that I had is the exception and not the rule, right? Most people like me don't get the same opportunities that I did at Texas Tech University. And so I'm always going to be grateful to my alma mater. But we need to recognize that collegiate recovery programs aren't just nice stories about our alma mater. They are a part of the solution in the recovery movement, that we need to create opportunities for people in recovery to be in C-suites. We need to create opportunities for people in recovery to be the judges on the bench. We need to create opportunities for people in recovery to have any job that they want. And, that starts in our local communities, like we've heard so many people say, and creating the opportunities to, go to college and get an education are necessary. And I think some of the things that we're doing, like specific things that we're doing different now, is that we have to stop using what our recovery beliefs are to support people, right? Like I came up in 12-step rooms, but when I'm working with students, I'm using recovery, I'm using the social determinants of health to manage how I'm going to approach working with them. I'm using recovery capital as the measure of what I need to be doing with that person. And I'm not just focusing on my personal beliefs, because all recovery pathways is supporting all recovery pathways is how we become equitable, right? Not just if I'm in AA, it's not just about supporting AA members. It's about supporting everybody, no matter what pathway they choose. And so that's what we're trying to do on college campuses. And, I think that we're doing a pretty good job, but we've got a long way to go. And I could, if I work in collegiate recovery for the rest of my life, and this is the focus of my work for the rest of my life, there will still be a long way to go. And I think that that's the most important thing for us to remember, is that this work is necessary and it's important, but there's no easy fix or solution to it.
Woo! Thank you. I'm a proud mama. I know you're going to punch me when I say that, because you're definitely not a child, but I remember where we were in 2013, and I just could not be more proud of you. So, thank you. And I have more questions for you. We're going to come back if we have time, especially around harm reduction and the way that you've integrated harm reduction within your recovery support services there, because I think you've really led the nation in a lot of your structure that you've created. But I do want to get to Dr. Villicent. And I mean, who doesn't use the BARC 10 and the recovery capital scale? And I mean, this is just I'm a little bit of like a girl fan over here for you. And so I want to talk to you about recovery research and where we are right now. We do not have enough time to really kind of go into that, a deeper dive, but we just love kind of your overview of where we are right now.
Oh, yeah, absolutely. There's a number of places when it comes to recovery research, recovery science that I could have chose to start, but you have to start somewhere, right? So, I chose to talk about a little bit today. I was moved by, Patty referenced stigma, and how much that has impacted the recovery movement. So I'll talk a little bit about that. I think about stigma. I think about recovery-related discrimination is what I think about, because that's kind of a consequence or an outcome of being part of a stigmatized population, is experiencing discrimination. And alcohol and other drug problems are among the most stigmatized conditions globally that result in discriminatory practices towards these individuals. Stigmatizing attitudes result in shame. It lowers the chances that individuals will acknowledge a problem, seek a recovery support service, or seek social support. And this in turn can result in a lengthy clinical course for these disorders. Now, anecdotal reports, even previous work from Faces and Voices, has suggested that affected individuals suffer continued discrimination even after they've resolved a problem or achieved long-term remission, which can undermine ongoing recovery efforts. And this can be especially true during the first 5 years of recovery, when vulnerability to a recurrence remains elevated. Such discrimination, it can take different forms. I think about it in terms of personal slights, or what we call micro discriminations, when an individual is perceived as untrustworthy or dishonest or always just about to relapse. There's also macro level discriminations, which are more violations of our personal rights, being denied the right to vote because of alcohol or drug history, or obtain employment or housing, all because somebody is aware of a history with alcohol or drugs, despite that it might be resolved. So, we did a nationally representative study to understand just how common these experiences are after resolving a problem. So we can also inform clinical and public health efforts designed to reduce these societal barriers to recovery. So in our own research, we learned that micro discriminations were more common than the macro discrimination. So specifically, about half the people in this country who have resolved a problem with alcohol or other drugs say that others assumed that they were likely to relapse. 38% reported that in recovery said they felt like they were held to a higher standard because others knew about their history. 25% of the people in this country who were in recovery said people still perceive them as being dangerous. And another 25% report being strongly rejected from their family and friends. Now, when it comes to those macro level, those more structural, organizational level types of discriminations that can occur, we learned that about 19% of the people in this country who resolved a problem reported being treated unfairly by the police because they knew about their history. Another about 15% reported inadequate medical treatment because they were aware of their history. 11% said that their insurance would not cover some of their medical costs. 16% said they could not get a job because somebody knew about their history. 12% were denied a loan. This comes down from policies, federal policies, particularly with education and stuff. 9% were denied housing. Another 9% denied nutritional assistance, and as well as the right to vote because somebody knew about their drug history. We found that people who reported these micro and macro aggressions, that was associated with higher psychological distress, lower quality of life, and lower recovery capital. These infractions, many of them are a direct result of our federal policies and our health insurance policies as well. And that's why I seek to highlight them. Now, regarding racial health equity, if I'll introduce that into the equation a minute, there's been a considerable body of evidence that has shown that racial and ethnic minorities, African Americans in particular, have suffered a disproportionate burden of health and social consequences despite having lower or equivalent levels of substance use or substance use disorders. In fact, in our own research of recovery-related discrimination, we found that all races and ethnicities reported similar levels, with one exception, African Americans. So this is my message for today. They were twice as likely to report losing their job because somebody knew about their history, 3 times as likely to report being denied housing because somebody knew of their history, 3 times as likely than anybody else to report that they could not get a job, and 4 times as likely to report they had a job but could not get a promotion because somebody knew about their history. Notice the employment effects happening there. These are the structural components that will need to be investigated for their disproportionate impact on individuals who identify as Black. By the year 2055, there will be no single racial or ethnic majority in this country. So it is important for recovery scientists and recovery support services to anticipate increasing diversity. We need to reissue building permits in terms of access to higher education, nutritional assistance, housing, voting, employment. These are the levers that we can pull to reshape the landscape of recovery. We need to change the narrative on how our institutions magnify harm from disorder, as opposed to minimize harm and promote well-being. I'll stop there. Thank you.
Wow, thank you. I've been saying for years that our system is completely broken and we need to get the system into recovery. And I think you just gave us the roadmap to be able to do that. So thank you so much. Wow, what a great panel. I have a question. I did want to follow up with, we had a question come in the chat in regards to harm reduction, and would just love to hear from each one of our panelists on how you see from your perspective on where you're sitting in your work, how are you incorporating harm reduction, either services or research or messaging into what you're doing there in your work? And Jen, we'll start with you.
Absolutely. So, the first time I ever thought about harm reduction as an approach, someone talked to me, it was a researcher was talking about doing the research to find if someone had used heroin 250 times last year, and then this year they used heroin 100 times. But those other 150 days, they were engaged with their family, they were working, they were engaged in their life and their goals. Isn't that better? And that there's no other disease that we would treat the way that we do substance use disorder, with that thinking, with the thinking of progress and having it be on a continuum. So I think the work that we know to do for advocacy is the work that we need to do about the many, many strategies of harm reduction. I think the community acceptance and understanding of it is not yet where it needs to be. And so the work that our peers can do and our community can do to describe the strategies and access to the strategies, so that that whole realm of aid is available to whoever needs them. So that's, I think, the work that we can do. We can talk about, certainly warm handoff is one strategy. Then, think about the work that has been done with naloxone over the last 10 years. That we can do that same work so that people understand the value of a fentanyl strip. They understand the value and take the fear away and help get to a shared understanding of this as a part of a whole strengths-based approach to the work.
Thank you, Jen. That's some great points there. Thank you so much. Ephraim, from your perspective, how are you incorporating harm reduction? Oh, I think you're on mute. I'm so sorry.
Sorry about that. The way we incorporate it here in Brockton, Stairway, we have an agency, COPE, which is focused on harm reduction. We partnered our outreach coordinator, and we try to pass it on with a couple of years to making sure that they go around and they do outreach, they pass some swag, and they letting know that we are here at the center. And we try to pass it with compassion and working around the issues. It happens very organically in terms of I was there, I went on that, I was there once, this is where I am now, you can do it. And it goes out 3 or 4 times a week, and go in the shelter, go around the places where the people are still hanging around, and making sure that they know the center is there for them. We also bring the Narcan trainings over here every month. We have a nurse who comes in the center on Wednesday, once a month, and try to teach them how to use Narcan and giving Hep C tests and all that good stuff. So That's how we implement it here.
That is great stuff. And I heard you say compassion. And it reminds me of a friend of mine in New York always says radical love and compassion. And I love that. Thank you so much for sharing that. Ahmed, I'm more familiar with what you're doing, but I don't think everybody else is. Can you just briefly tell us a little bit about what y'all have set up there?
Yeah, happy to. So I think first it was a perception change for us where we because we have to remain open-minded. And so it was about recognizing that abstinence-based recovery is on the harm reduction continuum. And so it's the ultimate form of harm reduction. And so because of that, when we start taking that approach, what we realize is that there's lots of services on that continuum that we're missing in our organization, speaking about my campus specifically. And so it's a campus effort to do things like we started a medication-assisted recovery program through our student health services. And so Ohio State students don't have to leave campus to receive that support. But then also, doing the type of outreach that we see our local public health employees doing. And so it's, getting the naloxone through grants, getting the testing supplies through grants, and then putting our feet in the streets and giving them out to students, and using the public health approach of, when we're doing our naloxone outreach, we're not just targeting drug users and we're not just targeting their friends and their loved ones. We're targeting everybody, because on a college campus, the likelihood of a student at a party coming across another student who's unresponsive is pretty likely and pretty high. And so we want to make sure that as many students as possible are carrying it and understand what they could do to save another Buckeye's life. And so that's the approach that we've taken, man. But I think most importantly, what we've done is stigma reduction campaigns on campus, because most of the harm that people experience is through stigma. And I think that Dr. Corey did a great job of explaining that to us. And so we have trainings that we do to help people learn how to become recovery allies. And really, we have made sure that we focus on the fact that we need to be providing love, compassion, and services to drug users. Because 15 years ago, I was a drug user that somebody loved and cared enough about to provide me with the services that helped me build the life that I have today. And so that's the type of work I need to be doing to everyone. Not just, I'm not there to just serve students in recovery. I'm there to create opportunities for any student who's struggling with substance misuse to get into recovery. And so it's for me, it was about our campus. It was about a perception change that recovery work doesn't just start when they leave treatment. It starts when they use that drug for the first time. Right. Yeah. And that I need to be working with prevention specialists and public health specialists to create a continuum of care. And it's not enough for us all to work compartmentalized in silos, focusing on just the one thing we do.
Absolutely. Thank you, Ahmed. Thank you for what you're doing too. I appreciate it. Corey, if you would, the last 2 minutes that we have, just tell us a little bit of your predictions, maybe that we can carry us over into Keegan's panel as far as research in the recovery realm and harm reduction, intersectionality, maybe.
Sure, absolutely. I'll say for me, as a researcher in recovery and race, the questions that I raise are going to be, long-term recovery. These are the things that we don't know. Is everybody just as likely to hit long-term, meaning 5 years or more? Is everybody just as likely to have long-term recovery? Do we have health disparities? These are the types of questions that we do not know the answer to, but that would be the best way to build out the science in terms of particularly systematically. We did it for substance use disorders, and we did it on the course of illness, from onset to seeking treatment and chronicity and on down the line, but we have not continued it through recovery. And in doing recovery, we need to embrace strength-based indicators. We do not need to pathologize the entire process all through recovery. We need strength-based indicators. We need to know if they think their life is worth living, not just whether we think pathology has gone down or if the drug test is negative. So we have to think broader, and we have to continue to build in the recovery science.
Wow. Thank y'all so much. I really appreciate it, and could spend probably another 3 hours with y'all. So I appreciate it. And I'm going to turn it back over to Liz. Thank you.
Thanks so much, Kristen, Efrain, Jen, Ahmed, Dr. Visalant. It was really wonderful to hear all the work that's going on. audience, I encourage you to continue to engage with them in chat as well as you have been doing, because they will stay with us as we move into the last but not least segment, where we are going. And I'm going to turn it over to Chris Kelly for that.
Thanks, Liz. And I was just thinking, what a hard act to follow. So Keegan, Christina, Mark, we're going to have to bring it. So here we go. Welcome. Thank you, everyone, for being here. My name is Chris Kelly. I'm a woman in long-term recovery, and I'm a project manager at the Peer Recovery Center of Excellence and the Great Lakes Addiction, Mental Health, and Prevention Technology Transfer Centers. All this talk just had me thinking about, that I too started my whole kind of journey, grew up professionally in recovery community organizations. And I walked through the door of an RCO after working 25 years in restaurants and was like, what's this all about? And started volunteering. And it was because of the guidance and the mentorship from the group of employees that worked there that helped me see something in myself that I hadn't seen before and see this potential that I can say now I get to work for the Peer Recovery Center of Excellence. And if you'd told me that 15 years ago, I would have told you, no way, that's never going to happen. So honored to be here. So honored to share this space with these wonderful folks. So I'm going to kind of do this, not necessarily a little differently, but Keegan. So Keegan, since 2013, Keegan has actively worked in the recovery field through roles in advocacy, counseling, and management. Person in long-term recovery since December 2009, Keegan has firsthand experience living and maintaining an active, healthy, substance-free lifestyle. And so Keegan, just kind of a short response first, but what are some of your perspectives on where the recovery community is heading?
So I think we're at a crossroads, and I'll say that it's really great to be here, and thank you for everyone for being here and honoring our panelists' time, and panelists, thank you so much for honoring the recovery community the way you have in today's discussion. I think that we're at a fork in the road with a lot of different experiences, and I think I really want to emphasize where I think we have opportunity to head, and I think a lot of that has been already leaned into this conversation. But I think kind of carrying from just moments before, looking at a harm reduction model, really. So I think that, all too often there are these different classifications of kind of harm reduction being a separate component of a recovery process, or a recovery process being a separate component from harm reduction services. And I think really looking at, like, fundamentally, how can we incorporate all of this together? The goal is to provide patients with what they want to receive out of services, and providing them opportunity to access them. So recently, Faces and Voices of Recovery, along with ASAM and Community Catalyst, had released for the first national examination, and just that, hearing from patients what they want out of someone's recovery process and treatment. And the results were astonishing to me, and not so astonishing to me. And so they were not astonishing because, in a lot of ways, it's what I would expect to hear from a person who wants to receive services. They want to stay alive. They want to reduce harmful substance use. They want help meeting their basic needs. They need further linkage to mental health services. And yet, so these are being the primary outcomes that someone wants to participate in. And yet our systems are not currently designed to provide those services to the people. So, and looking at, there's opportunity to really remove thresholds of services to people. I think, all too often we still live in a system that's very focused on outdated methodologies, which exists like punishing someone within a kind of human services program or a recovery community organization for having a behavioral condition. So kind of punishing an individual for acting out with a condition that we know to be related to behavioral health, and yet they're being punished because they have experienced an episode with their behavioral health. It doesn't make any sense. And unfortunately, like the what we have seen as a result in preliminary data in 2020 is that as a result of not being able to address the preventable overdose deaths in a more systematic way, 93,000 people died from clearly preventable overdose deaths. And that there's as mentioned earlier, there's a lot of disparity in that, and not specific to what I'll say really is that, like, there is an unprecedented amount of Black communities dying from overdose deaths. And so there's opportunity for really providing services that are inclusive and culturally appropriate to individuals. And so really paying mind to that, not just writing that into legislation and not just talking about kind of the buzzwords of our communities right now, which is like Black, Indigenous, and people of color like BIPOC, but really, like, how do we implement that? How do we provide genuinely appropriate services to people, realizing that everyone needs something different? And we can start the process of doing that by lowering thresholds to services and really realizing, again, as emphasized, I want to double down on something that Ahmed had said earlier. It's changing the conversation from a kind of particular path of recovery being brought into the workplace environment, which is like really inappropriate. It's like saying, like, I benefited from therapy like X in my own life, and therefore like only cognitive behavioral therapy is appropriate for all people who need mental health services, which is like not true. I mean, there's plenty of other services that work for different people. And so how can we provide services coming from a loving, caring, empathetic process that allows us to be able to do that? The other thing I'll mention is just really quickly is looking at teachable moments. How can we have teachable moments with each other? So there are hundreds of people on this call, and what I've seen in chat is a lot of people agreeing with what we're saying. There's a whole lot of energy around, like, yes, thank you, and I appreciate that. How do we get this conversation from the agreements of the kind of choir speaking to one another and rallying each other up and carrying this out into our daily lives? I think that there is so much utility in having teachable moments with people who have not perhaps heard an alternative, and then looking for ways to continue to navigate reducing stigma, as we've talked about, through some of the ways of showing people what an alternative is.
Yeah. Thank you for that, Keegan. So many great points there. And I agree, like, we, as a recovery community, sometimes we get so wrapped up talking to each other. It's like we just have to do a 180 and carry that message to the broader community, because it's such a wealth of information. I had the honor of working with Dean Lemire and Jim Wolfing, and really they helped me kind of adjust my lens to see the whole recovery continuum sitting under this umbrella of harm reduction. So we can look at like these points on the continuum, and really we all sit under this umbrella of harm reduction when we really look at the work we do and what we're trying to achieve. So thank you so much for that. And I think Mark's going to have some good things to say about this. So Mark John, again, I had the honor and privilege of working next to Mark at Minnesota Recovery Connection, and we've stayed in close contact over the years. Mark's a person in long-term recovery and is the founder, president, and CEO of both the Twin Cities Recovery Project in Minneapolis, Minnesota, and the Dayton Recovery Project in Dayton, Ohio. So yes to Mark, because that Dayton project just got up and running, and that's really exciting. Both are culturally focused recovery communities, organizations whose mission is to offer assistance and support to those who are or have been challenged by substance use disorders. So Mark, for you, what are your perspectives on where recovery communities are headed?
First, I want to say thank you, Chris, for having me, and for everyone else who allowed me to be in this space. And I just want to give a great big thank you to all the trailblazers who have gotten us to this point, right, and continue to push us. Great big shout out to my mentor, Andre Johnson of the Detroit Recovery Project, and my friend Corey Velzane, who is has been a great inspiration in my life as of recent. I see us making recovery available to everyone everywhere, supporting all pathways to recovery. And we know the history behind this movement, and most of those who participated in starting this movement came from 12-step 12-step programs. And so there's still a lot of stigma within 12-step programs associated with considering those who are on medication-assisted treatment as not a person in recovery. So continue to educate community as a whole. I see RCOs who are representing compassionate, empathetic, and empowerment services across the nation and other countries, having the ability to keep this movement moving forward, because there are dying people out there who don't need anyone else to judge them and to make them feel less than, to make them feel incapable of moving forward in life. And also that we are ensuring that we are creating diversity and equity in these spaces. And if you noticed, I didn't say inclusion because I don't like the term. I don't like the term inclusion because it signifies that you're just allowing me to be a part for the sake of. And too many times, speaking from an African-American standpoint, you know, like currently I'm on, I wear a lot of hats, right? But I don't want to just be a part of particular groups just because of the color of my skin. I want to be there because you really value the work that I do and what I have to offer. I think it should be, I hope, my hope is that we continue to evolve in this whole equity and diversity, and that it is a real practice and not just something loosely spoken about, right? I think it's going to be important for us to clearly understand the impacts of those who are suffering from SUD, and primarily in the African-American community, because our rates are increasing dramatically. It is going to be important for us to do research on our community, just like it's being done on other communities. So we need the help of the whole recovery community to make this possible, to ensure that we can offer the best practice services to individuals who are suffering. Because there are some things that individuals are really plagued by that are so traumatic that we wouldn't begin to even understand. And if we don't do the necessary research by creating the necessary assessment tools to get from the community, to hear from the community, then we're not going to know how to best serve them. So things have to be done in a very non-traditional way. We have to be willing to go the direction of the needs of the individuals and not the way that systems have been traditionally put in place. And I remember one time Patty had me speaking, and I was so excited. We were doing a community resource fair, and we had all types of resources out there. And I was speaking on my cell phone because I was participating in what was taking place in South Minneapolis. And I talked about harm reduction, right? And when I said it, it was almost like she was like, well, that shouldn't be separate, right? All RCOs should be practicing harm reduction. And I I conclude that that is very true. Harm reduction is not a particular program that we offer. Harm reduction is what we are and who we are in regards to meeting individuals right where they're at and not expecting them to be somewhere where we think they ought to be. Being able to love them and embrace them and support them and encourage them and meeting them right where they're at, right? Not saying that you have to stop using substances before we can even begin to help you, right? Because some places promote that. No, we need to be able to help you right where you're at. What are the needs that are most pressing in an individual's life that could even get them, to have a mindset that would be open to moving towards what we would call abstinence. And in some cases, they're not going to be. Right. And we need to be able to continue to serve those individuals as well so that their lives still continues to grow. Right.
Yeah.
So
yeah. Thank you. Thank you. Thank you. You got a full fan club going on in the chat there, Mark. If not us, the people who support and work in the recovery community, who is there for these folks? So again, thank you so much for the work you're doing. And Christina Padilla, you are a friend I have not met yet. So
greetings.
Yeah.
California.
Yes. What I have to say about you is what I know from your signature line. So you are Vice President of Education and Strategic Development and Chief Academic Officer of the California Consortium of Addiction Programs and Professionals Academy. So tell me and us what you'd like us to know about you, and then a little bit about what you see the direction of recovery communities going in the future.
Oh, wow, Chris, you opened up a can of worms. I tell you about myself. Okay, y'all ready for the 7 minutes? I'm just kidding. Well, first off, I just want to say thank you for the panelists. I think it was Keegan and Mark. Thank you so much. Testimonies and the information that you said. A little bit about myself is, I reside in California. I'm a national speaker throughout the United States on LGBT specific addiction, peers, you name it. Anything that keeps people alive and suicide prevention, count me in. I have a heart and a soul to keep people alive through my messages. So that's that part. And I'm Native American. You want to know that in Apache. Okay, so we call it Degote, which is a greetings in Apache. So that's a little bit about me. There's a million other things too. I have a 5-year-old little daughter named Charisma, but now I can go ahead and get started. All right. So, and then what was the second part? Where you at? I think you were floating around.
Dropped off for a second.
Where'd you go, Chris? And I love you. Have a K. And my pronouns are she and they. And then I go by the suffix of MX as called Mix Padilla, not Miss or Mister.
Perfect. Thank you. I don't know what you touched on, but I was asking about what you see the direction of where the direction of recovery communities going.
Where I see the direction, besides when we talk about recovery, it's statewide anti-stigma campaigns, okay? Statewide and a national level, okay? Also banning the box on job applications for background checks for individuals, a whole bunch of recovery reentry programs, for the workforce, so workforce policies for treatment. When people are working and, whether they're in treatment or, they've had a slip instead of saying relapse, but workforce policies, you know what I mean? For people that need to go into treatment, but then still need to feed their family. What does that look like? Recovery, residence housing, I see us doing a lot throughout. I mean, there's NAR, there's a lot of different other places that are out there, but also education for MAT, stigma in housing and employment, because there's a lot of stigma that's wrapped around that in the peer area. Also on campus for campuses, recovery centers, RCOs, different places that needs to be put on, on community campus, any campus that's out there. Community, any kind of campus that has to do with the universities. Also recreational programs for people in recovery would be great. Also, we talk about RCOs, more RCOs, recovery cafes that are out there that are blooming everywhere, anti-stigma training, targeted for the healthcare industry. Okay. And then expanding, on peer support and coaching availability, and how important that is, and expunging some people's criminal offenses that were 20, 30 years ago that no longer serve them is good. Also for the criminal justice population, substance use disorder programs inside of jails and prisons. Use of access of recovery capital, an RCO tool, recovery mentors, at treatment facilities, workforce readiness. What else can I say? I'm thinking, family recovery planning during treatment. Any of the stuff that's happening, bringing the family, reimbursement for recovery activities as an alternative to step downs in treatment. A lot of what else I think we need to go for is employee assistant programs. People that are having a hard time at home and things that are happening, that they've picked up the bottle or shooting poison into their veins. Like, how are we working with them? How is the employers working with them? Also improve the cultural sensitivity in the workforce. I think that's important. We spoke a little bit to all of that just a minute ago. Let's see, education campaigns. Let me think of what else. Needle exchange programs that are already in effect. That's very important. Community recovery drop-in centers, and also drop off, with the medications that are no longer needed, getting some more of those particular things. Safe consumption sites, a lot of places, where they can have clean needles and different stuff so they're not infecting and passing anything along on the streets, that there's actually safe consumption sites. But I know a lot of people, that's very controversy, but you talked about the future. You asked me, I tell you straight out. All right. Crisis response training. So important for our peers. Naloxone and training in all public places needs to be put out there. Family intervention programs. We already started with some more warm lines ran by peers. Online recovery groups, role models, where we can get celebrities come talk to some of the youth, some of the older adults, people like that, and promotion, or actually not promotion. Promotion of recovery stories. Tell the stories. I think that's important to tell stories, because the stories is so important, but actually help people tell the stories, meaning that we tell them in a way that it does not traumatize somebody of what has happened to us in our life. And the last thing I would say in the future, I don't know how much time I have, but I'm wrapping it up, is the American Rescue Plan that's out there right now. If anybody's familiar, and the coronavirus relief plan that California has earmarked about 78 million of recovery-oriented systems of care. Okay, so in other states, like mimicking that part, but also I'd like to see more growth for the RCOs and drop-in centers. That would be really important. So that's where I stand right now.
Yeah, thank you. I love your energy, your enthusiasm, and can't wait till I get to meet you in person someday.
All right.
Yeah. So a question came up from the chat, which is one I think we all experience time and time again, is how do we take these abstract ideas and synthesize them into actionable steps that affect that systemic change that we're looking for? So these are big asks, like we've said in a couple other questions. These would take days, possibly years to answer. So if you can throw in some snippets of wisdom, Keegan, do you want to tackle that one? How do we make this stuff actionable?
So if you don't have a mentor, a professional mentor, get one. Mm-hmm. And if you are a mentor, or if you identify as a person that's been in the field for some time and has a wealth of knowledge to share with others, get a mentee. So we're leaders creating space for new leaders. So looking around the room today in our virtual space, there's a fair chance that I'm the youngest person on the panel. And as a young person in recovery, there's something special about the energy that comes along with that. And I think that there's great opportunity to begin further dedicating space to the conversations about transitioning the current generation into the new generation. And so having that ability to distill knowledge to new people coming in the space, in as much opportunity to share resources and whatever word of mouth bits of knowledge and resources we've discovered over the years, has such opportunity to really allow others to grow. And I think is one of the most effective ways that we can take what we are doing currently and share it with still others. And so how do we make that an actionable step? I think is really an excellent question. And the other thing is, there's, again, hundreds of individuals on here. Sign up to the many newsletters that these organizations are putting out. Faces and Voices of Recovery posts out up-to-date information about policies and advocacy items that you can engage in. So much of advocacy is just sending a letter. And most of the time, letters are already pre-written. And so it makes all the difference. And I cannot tell you how often those things are overlooked and how much of an indispensable impact that they have when they get to your member of Congress, when they get to anyone really. Local business professionals, grant writing. All of that has such an impact on individuals.
Mm-hmm, mm-hmm. Thank you for that. Yes, mentorship. I probably have 2 or 3 mentors at a time. So I agree. It's part of my life. I can't really move forward without them. And I think here on the call, we have the Peer Recovery Center of Excellence. We have Faces and Voices of Recovery. We have the ATTC Network, and all of us as institutions could create space for those things to happen as well and support that, passing on of leadership and knowledge and everything that we do. Mark, if I give you a couple minutes so that we can still hear from Christina, what would you be telling people they can do to make everything we're talking about actionable?
They just continue to develop and build relationships amongst the movement. I think it's far too many of us who don't know each other. And it is, in so many times there is work being done in silos, but it's a testament to the work that I've been able to continue moving forward here in Minnesota, and now getting ready to start in Dayton, is because of the wisdom that I've gotten from Mr. Andre, and soon to be Dr. Andre Johnson, and just continuing to one of the things is not getting to, what we all are challenged by is not thinking we know, the answers, right? Staying humble, and keeping an open mind, the principles that we learn in recovery to execute. And someone mentioned here in the chat I saw about developing individuals from within, even our own organization. So I have a huge focus on servant leadership. I'm not the greatest, right? We wear different hats. We happen to have different titles, but we're all equal. So promoting that and promoting other people's greatness, and that's how we continue to elevate this movement. So because there are things to come from individuals that I wouldn't or couldn't have even thought of. And so it's very important for me to keep an open mind so that I can expand my growth and my knowledge and how we're going to meet the needs of the community. So I love sessions like this because we all get the opportunity to connect and get in the chat and say, send me your email, and then we can continue to communicate and continue to develop relationships. And I think what's very, very important is developing cross-cultural relationships.
Yeah, thank you. All right, Christina, it's all yours. We have about a minute and a half, so you're going to send us out.
Oh, perfect. Okay, I need you to repeat the question one more time.
Yeah, how do we make this work concrete? Like, how do we bring it to life? What's that, how do we?
Okay, so how do we bring it to life? Okay, well, not only just, we put legislation, not only legislation, but at our capitals, you know what I mean? And also a lot of peer-led advocates and staying in contact, the connection with all of us is so important. So having that piece, and then also not let it die out, meaning that the advocacy keeps going on. And if there is anything that is in legislation, that get a federal lobbyist, get a lobbyist in your state, and make sure if you have money to do so, to make sure these laws are passed so we can go ahead and be successful in everything that I named out at CCARA, to go ahead and name everything that I actually broke down, that's something that would be very helpful as far as advocacy and making something available to everybody so they can understand it. Because once you understand it, then you will support it. If you support it, because sometimes people can't support something they don't understand.
Absolutely.
All right, that was it.
Yay, thank you so much. Well, I'm going to wrap up the Where Are We Going section and hand it over to Liz.
Everybody take a deep breath. Oh, it's been marvelous. Recovery rich communities. Can y'all see it? Can you see it? All right. Let's thank all of the organizations that are doing this work. Chris, I think you mentioned many of them. Cindy, I think you have a slide that will share some of the information. Also, panelists, please, if you're willing to, share your contact information in the chat. Many folks have been asking about it. But this webinar is the exact reason why I've been doing this work for as many years as I have. Every time I come to a space with people in recovery, I am renewed, refreshed, challenged, energized, thought-provoked, all of those things at the same time. And so I'm just so honored to have been a part of this and to hear all of the great work that you all are doing. I think we have one other maybe housekeeping thing about we'd love to get your feedback on the webinar as well. And so Cindy, I don't know if there was either a link that was going in the chat or a slide with that as well. But I just want to thank each of the moderators while we're doing that and each of the panelists for sharing your experience, expertise, strength, and hope, intelligence, brilliance, wisdom, all of that. So thank you all.
Liz, I'll just speak for Cindy. I think she was frozen unless she happens to chime in. But yeah, Lori had posted earlier a follow-up survey if anyone wants to take it. And then the slides will be shared or the recording will be shared on all of these websites, which will be Faces and Voices, the PTTC and ATTC networks, and the Peer Recovery Center of Excellence. So, and anyone who registered will get it by email.
Super. So I know there were some questions that came in at the end. We'll take a look at those for perhaps a future webinar. It sounds like maybe research and maybe an interesting one and some others as well. But thank you all for your participations, for staying with us, and be well. Godspeed.
Real quick, Liz, before we duck out of here, Patty and I just want to talk briefly about our 20th anniversary Recovery Leadership Summit that is coming up here in just a couple weeks, October 3rd through the 6th. A few months ago, you would have had to have gone out to St. Paul, Minnesota, in the brisk area of St. Paul, Minnesota. Now you can do it from the comfort of your home, and you can find out all this great information, particularly about how to continue this conversation for the event that took place 20 years ago, which became the catalyst for what created Faces and Voices of Recovery, into the next 20 years of what that'll look like. Find all the information you could ever desire out about just this event, facesandvoicesofrecovery.org. We really look forward to seeing you there. I think it's going to be a great opportunity to get involved and network further.
Thanks, Keegan, for that. And it is in the chat as well, that my error for being that. So I appreciate you pulling that in, and we can also hopefully send it out to folks who may have dropped off before you got a chance to say that. So anything else from the center, Chris?
Just remember, we're a newly funded SAMHSA Technical Assistance Center. So we are the Peer Recovery Center of Excellence. You can go to our website, you can request technical assistance in helping develop the peer recovery workforce in your area. We work alongside and help build capacity in recovery community organizations. And we're going to be looking at how can we create more research opportunities and disseminate it widely so it's not so scary. And we realize as peers, we can fully participate in the research process. There's a place for all of us in all of this. So I look forward to the coming years.
I think that's it. Thanks, Chris. Thanks, Keegan. Thanks, everyone, again. Happy Recovery Month.
Happy Recovery Month. Thanks, everyone. Take care. Bye.
Can we sign off, Cindy, Lori?
Yes, you can sign off. Thank you. It was
It's good to see you
awesome.
too, sweetheart.
Thanks, Mark. It was great to see you.
Mark, you were wonderful. I'm telling you, a couple
That's
of you
right.
all, we can run for office. That's all I know.
Yes, yes.
That's right.
All right,
Have our
everybody.
vote.
Take care.
Thank you.
Everybody enjoy the rest of your day.
Thanks, Sebastian.
All right, so do you all do debriefs right after these things, or are we going to leave it for another time, another day?
Bye, everybody. Thanks.
Bye-bye, Jen. I think we'll probably leave it for another day, Liz.
I forgot it's late there. I'm like, okay, it's lunchtime.
Yeah.
All right.
All right.
Thanks,
Bye.
Cindy, Great job. Thank you so much.